As we get ready to begin this second panel, I want to just touch on a couple of things that really struck me as we were listening to the first. And one of the first points that stands out that I think is going to undergird everything else that we talk about for the rest of the day is the importance of holding up hope. That even though we have the ability to see what is, we have to have hope that we can imagine and achieve things to be better than what we see right now. We also talked significantly about the social drivers of health that include the domains of healthcare access, economic stability, education access and quality, the neighborhood and the built environment, and our social and community context. And we talked a lot about community, and we were posed with a significant question that all of us need to think about in our respective contexts and also collectively, that when we talk about community, who is represented versus who is missing? And when we think about that notion of hope and the need to organize and mobilize in order to see the change that we know that we can achieve, that we want to see, we also have to think about this notion of which bodies bear the brunt of maintaining that resilience that it takes to see that change. Which also leads to the importance of partnerships, with faith communities partnering with healthcare organizations, partnering with community advocates, and all of us creating, as Dean Walker is fond of saying, a new ecosystem, a new way of approaching the problems and the challenges that we face. So to level set from our first panel, and Dean Boulware so eloquently described the concept of health equity, this second panel is going to be undergirded by the idea of health justice, which Dana Bowen Matthew, in her book, Just Health, writes is the moral mandate to protect and advance an equal opportunity for all to enjoy the greatest health and well-being possible. And she grounds her book in the experience that she had of her family. The opening, the introduction of Just Health describes her father, Vincent, a man who she never saw work any less than 3 to 4 jobs at a time, including one of those jobs being a motorman for the New York City subway, that he was one of the few people that she knew who would wear a suit to work every day, that would go to school at night in order to become an entrepreneur and a real estate appraiser, who worked hard to provide for his wife and his children, and did everything that we talk about we're supposed to do in order to achieve the quote-unquote American dream. Her father died at age 49. And that is not the result of him not making good choices. Sometimes when we talk about these issues of health equity and health justice, we have a tendency to place this in the individual kind of choice category. But I'm reminded, those of you who may have seen a show called Little Fires Everywhere, Kerry Washington's character is in a heated conversation with Reese Witherspoon's character. And Kerry Washington's character says to Reese, you didn't make good choices, you had good choices. And so as we think about this concept of health justice, we have to emphasize the importance of laws and policy that will emphasize fairness in order for us to achieve the dream. So with that, I'd like to now open it up to our panel. Panelists, I invite you to tell our audience, both here and virtually, a little bit about how you come into this conversation, the work that you do, and also address this question. The first panel, we talked about how did we get here. And so as we kick off this panel, I want us to think about what keeps us from going from here to there. As a society and a collection of systems, what are we doing or not doing that keeps us from health justice? So, Dr. Gurcan, I'll start with you.
Okay, good morning.
It's on. It should push it up. Yeah, it's on.
Good morning. Thank you for being here, and thank you for the invitation. It's a great honor to talk about health equity. It is a very important topic for me. And then because I am an AI researcher, people say just, what do you know about health equity and other aspects. I actually was born and I grew up in Turkey in a small town that you cannot even find on the map. But when I came to America, it doesn't count. The small townness is measured by the number of traffic lights in the town. And then my hometown didn't have any until I was 12, and they installed it, and then they uninstalled 2 days later because nobody was using it. So I'm really familiar with the impact of poverty and health equity. None of my grandparents knew how to read or write, and so just coming from that background gives me a really interesting perspective. And of course, I have been an AI researcher for 30 years, and especially in medicine. And sometimes when I say that, people ask me if there was AI 30 years ago. And then, yes, there was. And then we have been applying AI to artificial intelligence to medicine. It is really important. Just I really enjoyed the first panel. Just there were, if I wanted to summarize in 2 words, just it was hope and vote. But in this panel, we are going to talk about action, and I'm going to hopefully convince you that we can do amazing things with the power of AI. And I will give you some specific concrete examples from our projects so that you can understand how we can use the power of AI to impact health equity. I'm extremely passionate about our patients. They are my #1 priority. And then every day when I start my day, I just think about how we can make a difference for our patients. And then the only thing that I have found that I think that's going to make a big difference for our patients and for our healthcare will be AI. Because just if we think about it, there are some serious challenges when it comes to healthcare in this country. So we talked about the aging population, and that brings a lot of diseases. And unfortunately, the number of healthcare workers that we have is not enough. When I first came 25 years ago in Michigan, I tried to make a dermatology appointment. The appointment was for a year later. And I said, there must be, you probably made a mistake. This is not a year later, right? And they said, no, it's just really a year later. And if you try to make a dermatology appointment today, the picture may not be different. So the solution could be, let's invest more money in our healthcare system. We already have the most expensive healthcare system in the world. So what are we going to do? And hopefully in the next question, I'm going to argue and then give you some examples on how we can use the power of AI to make a difference. Thank you.
Judge Harsfield. Yes. Can you hear me? My name is Denise Harsfield. I am a native of Winston-Salem, North Carolina. I am currently a retired district court judge, but I am an adjunct professor of law at the law school here at Wake Forest, where I teach juvenile justice in North Carolina. In the spring, I run a juvenile clinic where students are actually placed with attorneys in the juvenile delinquency realm. And I also do a number of pro bono projects at the law school to include an expungement program, to include a Know Your Rights program, and a healthcare advocacy program that are all done throughout the community through the law school. So basically, my focus today, and my focus can be broad, is from my law perspective, and it's also from the perspective that I've seen a lot in my 22 years on the bench, and they have helped to frame a different sort of approach for me. The other thing I'll say is this. my focus changes. If we were all honest, all of our focus changes when we think about what's important and what we need to help with and what needs to be done. My mother celebrated 95 years of life and is still living and is doing well. And I turned 70 this year. And my focus has now turned to how do I make it to 95? What do I need to be doing to protect myself? Disregarding DNA and other kinds of things that are sort of predictors of what may happen. What can I do based on that DNA that I know is out there to continue to have a long life as she has had, and that she can continue to have a longer life? But I come today from this framework. I have learned that poor people and black and brown people tend to use the courthouse and the hospital in the same way. Now, why do I say that? Why do you say that, Denise? I say it right here. When I first took the job, I remember looking into a courtroom one morning, and I was like, my goodness. So I talked to a colleague. I said, do you all have night court? And she said, we don't have night court. Why did you ask that? I said, well, when do white people come? When do white people come to the courthouse? I said, there got to be a night session. I said, I'd like to preside over that night section if it's one. I mean, I just, I don't see any. I just don't see any white people in the courthouse. And at that time, there were very few Hispanic individuals because they didn't use it either. It wasn't a place they were trying to avoid most of the time and just didn't use it. But I found out that hospitals were kind of the same way, but from a different perspective. What happened is the reason you didn't see a lot of people who had means is because they used the phrase that you hear on TV all the time. Oh, I'm going to call my lawyer. We didn't have a lawyer to call. We just got to the point where we have a number of lawyers who are actually practicing that we can go to. But we can't pick up a phone and call our lawyer and say, take care of this ticket. I was doing 10 over. Go get it taken care of for me. I was doing this. Go represent me. Go stand up and for my first appearance. You be my representative. We didn't have that luxury. Same thing with the hospital. I'm calling my doctor to see what's wrong with me. Don't have doctors. Don't do it. So what happens is we end up going to the emergency room for our doctor. Our doctor becomes whoever's on duty that night who heals us up and Band-Aids us up and gets us back to a place where when it happens again, we can't follow up with a primary physician. So what happens? We end up back there again. So from the bench, I saw many people who were in this similar kind of dilemma, and it made me understand the importance of healthcare and what it took to do it. And I'll just start with my basic story again. My basic story, I had a young man who had end-stage renal failure. He was young. And one of the things that he needed for a transplant was to be infection-free or to be as close to infection-free as he could so he could get the transplant. Everybody wanted to jump on the mama because the mama, just wasn't doing what they thought she was supposed to do. She was doing the best she could. The kid would end up with more infection. They would say it was the washing powders. They would do whatever. Anyway, I ended up taking the kid out the home at the insistence of the medical professionals and placing him with a baseball coach, a very unfamiliar kind of placement. The baseball coach got him to the place where he was actually able to qualify because of all of these things for the transplant. And when I was talking to Dr. Simmons this morning, she reminded me on this snowy day that this kid ended up getting a kidney transplant because there was a snowy day in school, in the Winston-Salem-Forsyth County school system. Some kids had an accident and actually died. That kid was able to get the kidney of the dead kid that was there. But it was a process. I had to go to the hospital. I had to go and stand up for this kid to get this kidney over and over again. So the message is, if you don't put people in these seats that are going to stand up and recognize and be a voice for the voiceless, we're going to be in this boat for a long time.
Is this, you got it? Okay. And of course, I would have to follow that. It's amazing. Again, good afternoon, everyone. My name is Courtney Crowder, and thinking about how we're showing up today, and I'll talk a little bit about my experience, because even in preparing and thinking about the conversation that we would have today, the word that kept coming to my mind was, and definitely after hearing the first panel, was intersectionality. You know, the issues that we're talking about and the way that we need to confront and move, we have to recognize that how education impacts housing, impacts employment, impacts opportunities for access to care. How I spend my, and I'll talk a little bit more about my own lived experience in a moment, but how I spend my days, I work as managing director of a firm called APCO, APCO. It's a 41-year-old global communications and public affairs advisory that's based in Washington, D.C. So my commute from Raleigh is about a 43-minute flight most days. But you know, through APCO, it was actually the communications arm of a law firm, Arnold and Porter. Arnold and Porter Communications became APCO. It wasn't terribly creative, but that's exactly how the firm was named. But now it's about 1,400 colleagues across 35 offices serving 88 markets globally. And we work on a variety of issues, one of which is healthcare. And we talk about global health and global health solutions. We're talking about everything from supply chain and public policy to taxation and research and development, all of which have a lens that impacts our community and the people that we care about and that you all advocate and serve every day in ways that are incredibly discreet but impactful when we talk about access to care. So I spend my day managing a firm that organization. But I'm also from Raleigh, North Carolina. I grew up in Southeast Raleigh. I graduated from North Carolina Central University. You know, like I'm from here, right? Somebody say Eagle Pride. I heard you. I appreciate you. There you go. And you know, and I think about, you know, what got me to where I'm sitting now and understanding the way that governance and politics and policy and advocacy and organizing, you know, impacts health access and outcomes globally and in fact in our communities, started for me just, you know, being you know, a sickly boy that they thought had a heart murmur in Southeast Raleigh, which, you know, someone talked about the stoplight. You know, we didn't have I'm my mom's 7th child of the 9 that she raised pretty much by herself. And her baby boy had this heart murmur that no one could really figure out, that turned out to be an actual condition that needed to be served. There were no specialists on our side of town. And again, we didn't have a household car till I was a teenager, so it was the multiple bus rides, visits to the FQHC that was mentioned. And I'm also looking at Ben Money. I see him in the room, thinking about some of the policy discussions that we have there. But it was my own personal healthcare journey that really, you know, and actually being able to sit on a bus and listen to the coughs and the moans and the groans as we all sort of made our way to try to get to sit in the lobby and see if they were going to, if the specialist was going to take a Medicaid patient that day. Don't want to skip steps and fast forward things, but I will. Getting a chance to eventually serve as an advisor to a member of Congress, eventually serve as senior advisor and legislative director for a governor, being able to help lead and revamp an organization that's operational in this state called the North Carolina Black Alliance. That is an intergovernmental organization of hundreds of community-based organizers that organize on a variety of issues, including healthcare, health access, health equity, and justice, working on public policy issues at the very local level and the state level. You know, spending time sitting on boards of hospitals, advising health systems that I get a chance to do today. But it still goes back to that very, very, very early lived experience and thinking about the intersectionality of it all when it comes to housing, healthcare, housing and education, employment opportunities, and all that, and how that impacts, you know, the systems that we're all advocating against or working with to try to create opportunities for our folks. So when I was thinking about the panel discussion earlier, how I'm showing up and what I'm continuing to think about today is how all of these systems deserves your time, talent, and attention as we move into this next phase of what's going on in Washington, D.C., and what's going on at the state level and how that's going to show up in our communities and in our congregations.
Thank you so much, all of you, for showing up and letting us know how you show up in the ways in which you do. And Mr. Crowder, you spoke about intersectionality and the importance of it and how it's coming up. And another term very closely tied to what you were talking about is also interdisciplinarity. That for us to achieve what we are seeking, we cannot operate in silos, right? Even on this panel, we have medicine, technology, law, and governmental affairs and public policy represented. And it requires all of us to come to that respective table in order for us to have the transdisciplinary solutions that get us where we want to go. I want to move to our next question, where we are going to drill a little bit more into the role of technology in health justice. So new technologies, including artificial intelligence, have the potential to impact health justice. Many people think of technology as a great equalizer, while others worry that technology can reinforce existing inequities. What are the ways in which technology can both help and hinder the movement toward health justice?
I really like this question. Thank you. So when it comes to artificial intelligence, there are two extreme thoughts and feelings. On one side, there's a lot of excitement. On the other side, there is a lot of fear. And one of the most important components of that fear is that, first there are just, the fear that AI is going to end the civilization as we know. And then it's going to take away all the jobs. And then the other aspect is, what if it amplifies the current health inequality? What if it really amplifies or propagates the current biases, implicit or explicit biases that we may have? And I think there is a reason to just, justify these fears. But on the other hand, AI has an enormous potential for us to be able to remedy some of the challenges that we face when it comes to health equity. For many people, AI came to their radar a couple of years ago when these large language models, ChatGPT, Google Gemini, became publicly available. How many of you have had a chance to play with these large language models? If you can raise your hands, please. So I see that a lot of you had an opportunity. For many people, when we talk about AI, this is the first time they experience AI in the form of a large language model. And I bet many of you were amazed how these models can answer you. You just say, okay, just tell me about, how the snow forms, appropriate for today, and then, and I actually give your answer as a poem, a rhyming poem, and it will do it for you in seconds. But how can we take this one, this large language model, and use for AI, for health purposes? If we just think about it, our current health systems are pretty complex. My wife had a surgery a few months ago, and then I was with her during the discharge process, and then she had discharge instructions. And then many of you might, if you had any surgery, you might have experienced this. So these instructions, they are actually written and expressed for a 12-year-old to be able to understand, but there are a lot of them. And then they give you a lot of this information at once. right? And then, or if you talk to your doctor, many times you just come back and then you Google what's happened because there is something missing. And then it's just because your doctor can only spend 15 minutes with you. And I just talked to my cousin's daughter who is doing her residency in Turkey, and she said that they have 5 minutes over there. So if you are complaining about 15 minutes that you spend with your doctor here, so it can be even worse. So what will happen is that we can really use, for instance, these large language models, and we are actually using them. How can we take this complex medical information and then present this information to a level that is educationally appropriate, culturally appropriate for people so that they can benefit from this information? This is one example. Large language models is just tip of the iceberg. There are a lot of artificial intelligence models. I have been working on many of these models for many years. For instance, we can use artificial intelligence to be able to detect, diagnose, and then treat diseases. I can give you many examples of these. The very first project that I worked on was for the detection of breast cancer. And many women here may have had the pleasure of getting their mammograms taken. And then you may not want to hear that actually up to 30% of the breast cancers are visible on those mammograms. After you went through all this trouble, they are visible. Up to 30% of them are missed, although they are visible, so they are not detected. So we actually develop artificial intelligence systems to be able to detect these things and then report to your doctor. That way, if they miss these signs of breast cancer, they can actually benefit from artificial intelligence help. And there are many such systems currently in use in this country. But what about health equity? Just, how is this going to change health equity? So let's say we detected breast cancer, and then breast cancer recurrence is a really big problem, right? So there is a genetic test right now that can really accurately tell you if this breast cancer is going to recur, so your doctor can change the treatment option if they know that your cancer is going to recur. This costs around $5,000. $5,000 is a lot of money in America. It's an impossible amount of money for the rest of the world. They cannot afford to do that. So what will happen to 4 billion people, 4 billion women who cannot afford to do this? Currently, we are developing with the support of the National Institutes of Health. In my lab, we are developing a project that is going to take H&E slides that are already developed and used to detect breast cancer. And then this costs around a couple of dollars. And then we are using this $2 slide to be able to detect the same amount of information. And instead of a $5,000 test, we are developing a $2 test that is going to make a difference. So this is just one example, and hopefully in the next round I will give other examples of how we can use the power of AI to make a positive impact for health equity. Thank you.
As we invite Judge Harsfield and Mr. Crowder on this question as well, thank you for giving us more context around what AI is. And one of the things that I note there is that we think about the outputs, but you also call us to think about, well, what are the inputs that are informing the outputs? So I'd like for us to keep that in mind as well as you all respond to this question about how technology can both help and hinder our movement towards health justice.
I do appreciate the knowledge that I just received about AI because, from an educational perspective, you think about students who are able to put the exam into written word and come out with all the right answers, and that becomes scary. And in a world where plagiarism still has its obstacles up and down, you still worry about how much of this is original and how much of this has been contrived by this document. So I'm thinking better about AI in this healthcare situation than I do in the educational arena. But when I thought about technology as it is now, I do think there have been some amazing advances. And one of those, I think, is one of the good things that COVID brought about, and that was the teledoc. I think being able to talk to your doctor on your cell phone or in other media was really good. It kept down people from being around each other and did a lot of other things. I think MyChart is a great instrument for being able to, actually MyChart gives you the information. I went and had some blood work done, and I knew the results before my doctor even got them. So that can be scary too, but that's a whole other story. But I do think that there are a lot of things. And then I moved to the Google, and I heard you say that your wife got her post-op kind of instructions after the surgery. So what you immediately do is go and ask Google, and I'm telling you, don't do it, because if you got some kind of symptom and go to Google, you swear you died in the next 24 hours. So you need to call your undertaker quick, because it can be a very scary experience. But I do think that technology has made some very good advancement. But I do think that there's still significant fear among poor people and black and brown people about the doctor in general. We grew up, I had a grandmama, I don't care what you told her was bothering you, she had one remedy. And that remedy was called laxative, castor oil. She thought that castor oil, y'all know what I'm talking about. She thought that castor oil was the best prescription for anything that may be ailing you. Only rule was stay close to the house. Don't go too far. But at the end of the day, we still, utilize some of that homeopathic and some of those old remedies and refuse to get rid of them because we have a fear of going to the doctor. And it's the same thing with the mental health situation. Everybody probably has had an uncle or an aunt or somebody in their family that you didn't see that much. They kind of hid them up in a room or put them somewhere and let them come out on special occasions. And it was clear that something was wrong, but nobody admitted to it. Nobody wanted to do it. And it's hard to break those kinds of beliefs and traditions. No matter how advanced we get, we still lean back to those. I'm going to shout out our wonderful public health here in Forsyth County. And I have been participating in a program that's on the first floor of the health center. It happens like twice a Tuesday a month. It's called Men Talk. And they have invited me in several times just to bear their heart and talk about legal issues and other things and health care for their kids and those kind of things. And even though we're just in a room, and, the other week we had like 72 men that actually came in there, which was amazing, to actually discuss these sensitive issues about these kinds of things. So those kinds of things are opening the door for a freer discussion so that we will understand the importance of utilizing these things that we have access to now, but have fears that keep us from doing it. My final thing is that I was talking to my comrade here, and I was talking about, why I just read that Walmart was taking away all their DEI. They're not dwelling in that anymore. They're not trying to do that. And I think about book bans and those kinds of things that are out there, and a history that I finally understand the rationale behind that reasoning. And it's this. I don't think that the majority really want us to know just how bad and powerful we are. To hear the stories of overcomers, to hear the stories of midwives, to hear the stories of people who have healed, to hear the stories of folk in little communities who were able to come up and do some amazing things with nothing. To start a pharmacy in your place, to start a clinic in your place. They don't want us to know that, because what that happens is that generation that I think has been misled in so many ways, from Gen Xers to whoever, they will finally understand that I didn't do this by myself. It was the power of an almighty God and the people who heeded his word that got us to where we are today. So I think that technology again comes into play, because we got to let them continue to read about those who have come before that have made the way for things like AI to even be possible.
And I continue to struggle with this microphone. And we're also going to have to adjust this seating arrangement in a minute. I can't keep the judge here going to blow me off the table. Listen, so the conversation is about, the innovation that is AI and other technology innovations that are happening globally, the policy discussions that are happening there and federally, and then of course at the state level, and then ultimately how it reaches our people. Because to me, and what I'm sensitive to in this moment is that all the innovation in the world is stymied by, first, the commercialization of the innovation that happens, how much it costs to actually, be able to be accessed by folks. We all saw it happening real time during the pandemic as we watched the testing, then the vaccines be developed, deployed, and the question was, and it moved faster. Why? Because there was a public payer in the government, right? If you had to wait for the private sector to show up, or private payers, consumers, to actually get to the place where they could afford whether it's a $5 or a $2 solution, it would have taken that much longer to be able to provide relief to the community. So again, I think where we place our focus in terms of from an advocacy perspective is often in, it's that research and development to the commercialization to who's ultimately paying, and then how are we able to access it in the places where we actually need it the most, which I think is sort of, the conversation that we're having. But it's understanding what each of those steps might be, and sort of how close or how far away those solutions are from the people at each step, and who has access to it first. Obviously, the ability to pay, as we sit in a state that just obviously, thank you, Senator Lowe, Medicaid expansion, one of the last states in the country to actually have it. But that's all about the ability to pay and who can access a solution once it's been commercialized and able to be accessed by people who have, the means, which again continues to be a place where we can focus advocacy. Because again, technology, AI, to whatever the actual innovation is, how close can it get to the people and how quickly?
That is a great segue into the next question. But before I go there, I appreciate you bringing the innovation that resulted from COVID into this conversation, because, for those of you who are familiar, the Faith Compass Center focuses on the intersection of faith and HIV. A lot of our ability to get to a COVID vaccine and get any kind of medical treatment comes out of the work that was done around HIV, but we haven't seen anywhere near that kind of acceleration in HIV, where we've been dealing with this for 4 decades, versus the amount of mobilization that there was around COVID. So I appreciate you bringing that into this space.
Not to be super cynical, but obviously it's ability and willingness to pay. Who is the payer for the solution? And again, it sort of places an emphasis on why, again, to the point that the earlier panel was making, and elections have consequences, and the opportunity to find a willing mover, payer, to fund the research and then fund access to the innovation. Often for our communities that happens in the form of the public sector.
Let me just comment quickly. I agree. I think that COVID did, like I said, had some great things that happened to come out of it. And when I think about the reasons that, the federal government was so quick to kind of come in and do what they had to do, it's because it was non-discriminatory. COVID, everybody had it. Rich people, poor people, everybody was in Costco trying to get toilet paper, whatever they needed to get, because it was non-discriminatory. But when you look at things like HIV, sickle cell, those kinds of programs, they don't get the attention because they are specialized and generalized to our DNA and to what we have, so that you couldn't get that kind of response. So hopefully we learn from COVID that, it doesn't always have to be everybody, but we need to look at segmentalized kinds of people in order to make it work. And it can work because COVID proved that it does work.
But so, oh my gosh, we could go on. But I want to pick up on that point as we go into our next question, around the universality and the ways in which we even think about health, right? So we often think about health in an individualized way, right? What are you doing? Like, what behaviors are you performing? What kinds of medical treatments are you seeking? But health is also social and community, right? If I am not well, then that means that my community is not well, and that translates across different conditions and diseases. So, Mr. Crowder, because Judge Harsfield precedes you a couple of times, I want to come to you first. for this question, and then I'll start the next question with Judge Harsfield. Health justice is undergirded by having laws and policies to advance it. Those laws and policies are often informed by different sources. Sometimes it's the population level data, and then sometimes it's individual narratives that end up shaping public policy. Some policymakers value or rely on one set of sources over another. How do we balance diverse sources of data to get a fuller picture of the way forward?
So look, I chair advocacy for a global, advisory. So it's, if all you have is a hammer, everything looks like a nail. My answer is advocacy, right? It is about how do we communicate and inform voices that can, and then literally, map those influential voices to the people who are sitting in the seat making the actual the decision. What it feels like right now in a lot of policymaking circles, unfortunately, is that data, no matter where it's sourced from, is met with a lot of skepticism. And the data that you are willing to be sensitive to, it really depends on the source. So a policymaker is sitting very often being biased to the source of the data that they're actually being presented. I think tell me I'm not alone in this, right? Okay, all right. So if you have a policymaker that's biased against certain data and where it's being sourced from, then what you end up having are these broad, sweeping public policies that are based on nothing more than anecdote. The last person that talked to them, the article that they read, really not even an article, an editorial, or a social media, feed that's curated for them based on other things about their life and their persona that's now being targeted and pointed at them. This is happening globally, federally, state level, and very locally, quite literally being able to hyper-target data and curate it such that the data is almost individual to the policymaker. So a broad solution that impacts all of us based on anecdote, or a solution that they're not willing to consider because it's coming from a source that they look at through a jaundiced eye. What we're going to need as a community to continue to do is to be in closer relationship with each other. No matter where we sit in whatever professional or faith discipline we're coming from, we have to be in closer relationship with our community and at the center, and let that guide our activities. So center the community, center the people that we are trying to help, and let our movements, the data, the storytelling that comes from that, be guided by that. And so hear me say that data is incredibly important, and we have to continue to find trusted sources and serve that up to our policymakers in a way that's going to help them make the decision that we want. But we have to do that while we're also arming our people that are impacted by the moment with the same information and helping them move and focus and hold those same elected officials to account.
Judge Harsfield.
The guiding focus for most of my deliberation is, fortunately or whatever, is the Constitution of the United States and the Supreme Court of America. And I think that we saw the power of how these things get translated into health issues and other issues in this last season. We've seen it before. When I go back and look at the health law cases that have come down the pike in, let's say, the last 10, 15 years, we should have seen it coming. We should have been paying more attention. But as the court got stacked in different kinds of ways, it started shifting and moving in some ways that we didn't see. Hobby Lobby was about basically providing health insurance for people to get transgender operations and do those kinds of things. And we know how many times we saw that commercial with Kamala Harris with those transgender images that were horrific and horrifying, to say that, we still don't like that. That's not a healthcare decision. Yeah, maybe health can change the gender of somebody, but we ain't paying for it, or we don't think it's right from our religious box or from our economic box. We don't think we should be using our money that way. Then we had the whole Chevron where we looked at state laws that were dealing in healthcare and how there was some pulling back, and if there was some old law in Idaho or someplace that restricted hospitals from doing certain things, then that rule applied. Then, we had the 5 justices that overturned Chevron. Then, of course, Roe v. Wade, which came from the penumbra, that came from the First Amendment, that gave women freedoms and all kinds of ways to improve their health and to do things and to care for their own bodies, that led to the Roe v. Wade abortion. And then we saw it whittle down until we got the Dobbs, which is the ruler today, which was a big part of this whole election to start with. And one of the things that still just blows my mind about this election and this health issue is that I know I went to dozens of women's rights kinds of forums and issues, and I heard women say, my daughter is not going to be able to have the freedoms that I had, 50 years ago because they've whittled away at them. And when I looked at the voting records and saw who voted, I was like, come on, were y'all just playing? Y'all stood up there and said that you didn't want your daughter, and yet and still you voted for the man that you knew had stacked the court to take it away. I still am blown away by that. But, but back to health care. So go to you, to yours, I think that we have to watch the progression of everywhere. In the doctor's office, in the courthouse, and in everywhere, because ultimately these decisions are going to be controlling, not just from a congressional whatever point of view, it's going to be from the court. The court is going to be deciding what our health care systems look like. It's going to be deciding what we can and cannot do, who the people that are looking going to be, and ultimately it's that branch that's going to make the widest and most sweeping decisions about our lives. So we need to stay, in tune, not to the point of a law professor who probably has to do it, but to the point of understanding what the court is saying and how we are putting people on the higher courts and the federal courts. They're going to make decisions. They're going to change the way we look at health care in America.
And Dr. Gurcan, just before you offer yours, I want to build on Judge Harsfield's great list of judicial cases that have come forth. And I also want to add to that list Braywood versus Becerra, which is a case involving pre-exposure prophylaxis, or PrEP, as HIV prevention, and a company in Texas who basically is suing or has sued the Secretary of Health and Human Services, saying we don't believe in that should be part of the insurance that we offer because we believe that that's going to be supporting a lifestyle that we don't accept. So thank you for opening up that list and bringing that into this space. And so, Dr. Gurcan, as we come to you on this same question, thinking about how decisions are made, especially because the technologies that you're working with, many of the applications are new. How do we influence and provide information to policymakers about making good decisions that will lead toward health justice?
Everything we do in artificial intelligence depend on data, and then the quality of the data, and then how diverse the data sources are and how reliable the data sources are make a huge difference when it comes to the good quality decisions that you can make with the help of AI. And there are challenges when it comes to AI development and data. And these challenges have a lot to do with the society. So Pew Research Center did a study, and then they asked different age segments of the American population how they would feel about AI's use in healthcare. So what they found out is that the answer depends on race, it depends on age, it depends on education level. And then for certain segments of the population, there's a great mistrust in the use of AI. So what does this mean? This means that there are segments of the population that will not benefit from the power of AI because they may not trust the system, there may not be trust issues, there are historical reasons for that. And then this also actually factors into the collection of data. So when we get grants from the National Institutes of Health, we report, we just say, we are planning on recruiting 400 patients or 1,000 patients. And then here's going to be the distribution of these patients. So many of them will be women, so many of them will be African American, Hispanic. And in many cases, it may be really difficult to find enough samples in certain segments because they may not really trust the system. They may not participate in clinical trials, or they may just opt out of giving their data to be used for AI development. So these kind of challenges will propagate the problems that we face when it comes to health equity. Because if I don't have enough Hispanic American people's data when I'm developing my AI system, what do you think it will do? Just, it may not really be accurate or comprehensive when it comes to Hispanic Americans' data when it comes to deployed in the system. So how do we solve this problem? We really need to work as a group. So when Dean Boulware asked me last year to start our Center for Artificial Intelligence Research, one of the first things I did was to actually reach out to the law school here at Wake Forest. And then I reached out to health equity experts, and I reached out to our medical educators. And then they always ask me the same question: why are we talking to you? And I just say, AI development requires a village. We really need to develop these things together. We really need to have the legal perspective when it comes to AI. We need to have the community perspective. And that way, when we develop these systems, I think it's going to be impactful. Otherwise, we are going to continue to face these health equity challenges. And then this is important, just, for instance, we have a project. It's in collaboration with Duke and UNC Chapel Hill, as well as Wake Forest University School of Medicine, and I lead the Wake Forest portion of the project. This is an NIH sponsored project. We are looking at developing AI systems to help maternal mortality, and especially in African American women. And I don't know if you know the statistics when it comes to maternal mortality in African American women. We're at the bottom of the world. Just, it's mind-boggling. Why is it that just, the most richest country in the world would have the worst outcomes when it comes to maternal mortality? So for that project, we are working extensively with people who can reach patients. And then that way, just, this could be, the OBGYNs, this could be nurses, and this could be doulas, so that we talk to them and then we get their input and feedback. And this is going to be important. And another important aspect, because we are an educational institution, we actually noticed that there was not enough diversity when it comes to AI developers, AI scientists. So we went to the NIH, and then we applied for a grant. And then in the last 2 years, we have an internship program so that we are developing more diverse workforce when it comes to informatics and artificial intelligence. Again, just, those are all of our interns, and I think we all need to work together. Everybody in this room, we all need to work together with those people so that we can educate our communities, we can educate our students, and then we can educate other people who can really deliver these best practices to our patients. Otherwise, just, we cannot change anything. We can talk about it, we can continue to talk about it, but nothing is going to change. And if the title of the panel is action, and I just urge every one of you to really learn more about AI and to just become members of our center. It's open to membership, and then benefit from our activities. We have a lot of educational activities, and then whatever area you are specializing in, I think we need to join forces with you to make sure that we can really make a difference for our communities. We are in the Appalachian region, so just when I develop these health equity-related projects, people say, "Just are you developing this for India or Africa?" And my wife is from West Virginia, and I visited some poor towns over there, and I know Cairo, West Virginia. So when I think about these projects, I think about Cairo, West Virginia, or the poor towns in North Carolina. So for those people, the only way to make a difference is to really use the power of this technology and develop these things together, and to make sure that we can really change people's perceptions about these powerful technologies, so that in the following years, everybody can take advantage of them.
Thank you so much. And again, ecosystem is a recurring theme through all of our responses, and I thank you for that. As we prepare to close, I want to do just a quick lightning round. I want to pose a question to close out this panel, and if you can give us your response in 30 seconds or less, because we want to make sure that we stay on track for lunch. We've talked about the importance of getting out of silos, and you just alluded to that. From your perspective, and as you open up this panel with how you are showing up to this discussion and this work, what is it that you need from other sectors in order to advance the work that we all want to do together? From where you stand, from where you sit, from where you work, what is it that you need from some of the other sectors that we have expressed today, and maybe even others, in order for us to move toward and achieve health justice? And Judge Harsfield, I'll start with you, and then go to Mr. Crowder, and then Dr. Gurcan. 30 seconds or less.
I think what probably I need this in every situation is I need to know what other folk are doing. I see too much duplication of effort. And I know that AI or some instrument can create a booklet that shows us what every nonprofit, what every religious sector, whatever they're doing. Let's not keep doing it for that little grant that you got. Let's put our monies together and do something on this topic that can make a difference for more.
Yes. 100% agree with that. And also creativity. I think, if we're going to fully leverage innovations and really bring those innovations closer to the people in a way that makes the most sense, and take what people are used to doing with what needs to be done, then we have to be creative about the solution. We have to be imaginative. I love the word hallucinate. We have to hallucinate a little bit about what the future can be if we can just be a little bit more creative about it.
We cannot keep on doing things that we have been doing for many years with worse outcomes. We need to try something new, right? And that thing new is artificial intelligence. I really want you to think about artificial intelligence when it comes to health equity. So every time you think about health equity, think about artificial intelligence. And please learn more about artificial intelligence. Please don't be afraid about it, and then propagate this message. Thank you.
Thank all of you. Let's please give our panelists a round of applause.